initial questions or comments about the article I sent you guys home with last week? Yeah.
There's one part of the study that they couldn't address because people had not completed anyway, and that was exercising for 10 or more minutes, 3 or more days per week.
Okay.
Out of both the TTG and BEI groups, they were not able to get a good enough results from that section of
Okay.
self-care.
Okay, very good. And why do you think that's the case?
Because most of these participants were elderly,
Okay.
and one, I don't think they want to exercise at all, and then they probably just don't have the energy anymore.
Okay. So, just to kind of catch everyone up to speed, who can kind of give me a summary of what this article was about?
It's pretty much about how they randomly pick participants who have heart failure and or like a history of it, and they chose some of them to be the control group and some of them to be the one that they tested by calling them and giving them lots of extra education for a prolonged amount of time, and then they were just trying to figure out, you know, if this would increase the survival rate, I guess.
Okay. What were they trying to measure as an outcome of the study? What were they trying to measure? Like, they did the study to measure what at the end, right? General knowledge and what else? Okay, they didn't test for medical literacy. That was a factor that they looked at in the patients. Yes.
Self-care behavior.
Self-care behavior. And you want to comment on that?
The heart failure or quality life.
Okay, so knowledge, behavior, and quality of life. So they did these two different methods of teaching. So one was a single teaching session at discharge versus an ongoing counseling session for over 3 to 4 weeks, correct? And in the end, they wanted to learn if their knowledge improved between the two groups, if their self-care behaviors improved, and quality of life improved. Okay, so what's heart failure? I know you guys read it and found things you didn't know about and you researched it, right? Right? Yes. So what's heart failure?
Pleasure.
Anyone know? Heart failure? The word in red that the study is about? Go ahead.
It's a condition in which the heart cannot pump blood to the rest of the body.
Okay. That's a good start. Anyone else have anything to add to that? No? Yes.
Can lead to respiratory issues such as asthma and white hair elevation.
Okay. So I'm going to give you guys a little pop quiz because I know you guys are going to pass it. So we're going to try to define these terms, and you guys should have this in your packet on the first page, second slide. So what's a randomized trial? Someone else besides
Sergio.
Sergio. Yeah.
They randomly
Randomly
chose participants
from where?
from
From a office?
an office, or a doctor's office with people with heart failure.
Okay. Where are these offices? Were they like around the world, or was it every heart failure office in the country? They do address this, so you guys can jump in if you guys know the answer. They do address this in the article. Yes, in that.
They gave like 4 different places, and one was Northwestern University. They had the Division of General Internal Medicine, and then they had another one at Chapel Hill in UNC at the Center for Health Services Research, and then also another one at UCSF, and then I think there was also another one at UCLA.
Okay, so they have like 4 or 5 centers they pulled from, right? Some on the East Coast, some on the West Coast. So when we say randomized trial, what do we mean by randomized trial?
Because after the initial education session, participants were randomized to either the intervention or
randomly put into either BEI or TTG. They didn't decide, okay, if you're male, you're gonna go to one group, if you're female, go to another group. They just chose randomly, okay? I gave you guys all a number, and I put all the ones in one group and all the twos in one group. That's random. There's no order.
You guys are all currently part of a randomized trial. Glue is a randomized trial. Some of you got into online, some of you got into residential. It was random how you got put there, for the most part. So if you can think about it that way too.
What does the word exacerbation mean? Worsening. So what does it mean for something, for heart failure to be exacerbated? What are some of the symptoms of exacerbated heart failure? Sergio? Anyone else know besides Sergio? Symptoms? Go ahead.
You have fetal edema,
There's
swelling
what's
of the
fetal
feet,
edema?
swelling of the feet.
Okay.
You also have fluid retention in the lungs.
Which means what?
You're not able to get rid of all the fluid that's coming into your body.
Okay.
So some of it gets stuck in your lungs.
Correct. What else? Anyone else know?
Shortness of breath, especially when you wake up.
Okay.
Weight gain.
Weight gain. What kind of weight gain? Like a pound every day, a pound every month, a pound every hour? What kind of weight gain are we talking about? What's different about this weight gain than me going out and like binging for 30 days straight and gaining weight? How is this weight different? Anyone know? Okay, so when people with heart failure gain weight, what is the weight from? Is it from them eating too much or what?
It's because they can't get rid of the water in their body.
Right. So this weight gain is something very astronomical. It's like a pound a day. So imagine yourself, a little old lady, she's like 80 years old. She should be about 90 to 100 pounds. And then in a week or so, she's 120 pounds. That's something terribly wrong. And that's something that happens a lot in heart failure. Some of the patients don't recognize this weight gain, especially our overweight patients, don't recognize this weight gain as a sign of worsening heart failure. And all of this is from fluid, and before, in a very severe case, the fluid can't come from your body to the lungs. And you can drown, or you can have a good feeding ground for pneumonia. So that's something that's really common with heart failure patients. Okay. Any questions about that? So any other symptoms of heart failure exacerbation? You have the weight gain, shortness of breath. Anything else? I think you guys kind of covered it. There are some that are pretty much common side effects or common symptoms of heart failure that doesn't really indicate an exacerbation, but it's kind of annoying. So they may lose their appetite because blood is not going to their stomach, and they may eat something because they know they have to eat, but they have to throw up because they don't have the blood and the oxygen going to help them digest their food. So they might not even want to eat anymore. Sometimes they get depressed because blood is not going to the brain as it should. Sometimes they get really tired and sleepy. They don't want to leave the bed. They can't really do anything. They just want to sit there. So these are some of the common side effects. Readmission. What does readmission mean? We spoke a lot about readmission.
It's like just being admitted to the hospital over and over again.
Right. So with heart failure patients, one thing that's, the reason I chose this article because of Obamacare. Anyone heard of Obamacare? Anyone know how this relates to Obamacare? No? Okay, so one thing that hospitals are doing now, they're freaking out because under the Affordable Care Act, they're saying that if a patient with heart failure is readmitted within 30 days of being discharged, the doctors would not be paid for the services. And why this is so important is because patients with heart failure, they are usually readmitted within 30 days. So they go to the hospital, they stay there for a week, they get out the hospital, next week they're back in the hospital. They're in there another week, they're out maybe 30 days or 28 days, they're back in the hospital. So this is a big deal because this is costing a lot of money for Medicare and Medicaid. And most of these patients are on Medicare, which is a government-provided health insurance policy, correct? So we're spending all this money on people who continuously come to the hospital with these very expensive procedures. So that's why readmission is very important in heart failure. Okay? So what is Medicare? Spoke about Medicare in introduction a little bit.
It's healthcare for people that are 65 and older, like other people with disabilities.
Okay. How are we affected by Medicare? Even though we're not old, how are we affected?
We, in our salary, it takes it out as far as taxes.
We pay for it. Each and every one of us, when you start working, you might not work now, but when you start working in your tax, you have your taxes from state and federal, and you have this little line that says Medicare. Sometimes it's like something really small, like 65 cents or $1 or $5. It's not that substantial, but when you add it up and everyone in the U.S. is paying it, you're paying a lot of money to Medicare. So a lot of people are saying that they don't want to pay for it, they're not using it, but it's how we're pretty much supporting our baby boomers now who are at this age level. So, you know, that's why it's so expensive now, because it's a whole lot of old people, and we have to help them. We have to pay for them. Okay? Health literacy. We spoke a lot about health literacy. What does it mean? What do we mean by health literacy? In the grade.
People understand like terms, like medical terms,
Okay. Why is that important?
so like they know how to treat whatever like any symptoms they might have.
Okay. So how many of you have been to the emergency room before and your doctor tried to tell you what's wrong with you, and then you go to a pharmacy, try to explain how to use the drug, and you kind of like, I guess I can take one a day. Anyone ever been confused by that at all? Or you like clearly understand? It's like so clear to you. Kind of like whatever kind of action parents, yeah. So imagine if you're illiterate in the first place, not just health illiterate, but you can't really read, you're old, you really can't see that well, you have heart failure. How do you think they will understand this very complex disease? Do you think they understand it very well? Do you think it's easy to understand? No. Okay. So let's move on to IRB, which is the Institutional Review Board. What is that?
It approves, monitors, and reviews the biomedical and behavioral research involving humans.
Okay. What does that mean? Anyone else?
It just basically like watches over any testing on humans or anything.
Right. Whether it's a survey, whether you're getting a shot, whether it's this like new treatment for cancer. If you're doing research on humans, you have to report to your IRB. You guys may do research in college, you may not, you may do it beyond college. But the IRB is going to be either your best friend or your worst enemy. They determine everything that you do, like down to the questions you ask. Every little thing you do has to go to the IRB for humans. Okay, for humans. All right, informed consent.
It's like you can't just give someone a child, like some clinical judge, you can sign off on it and know what they're getting and prove it first. Because it's giving consent.
Okay, anyone else want to add to that? Very good. Informed consent, it's not very hard, guys. Just look at the word informed and consent. Any interpretations of this at all?
Basically, they just have to know what they're getting themselves into before they can bring a decision.
Right, so before any human being at all, doesn't matter if they're a prisoner or a homeless person or a college student or whatever, they have to go through this process of informed consent, meaning that all the benefits, all the risks, all the what ifs, the possibilities, a slight chance, anything that may or may not happen, you have to be completely informed to the best of their ability. They cannot leave out anything, okay, before you agree to sign up for a study to be a subject. Okay, so we already discussed heart failure. So what is class 3 through 4? They talked about the patients had to be class 3 to 4 on the New York Heart Association scale. Anyone look that up? No? Anyone remember that from the article? Yeah. Okay, so the New York Heart Association has this scale where they pretty much rate heart failure and it's based on the symptoms that you have. So we have class 1, 2, can everybody see this? 3 and 4. Clearly 3 and 4 are the worst. So with class 1, it's kind of like no symptoms. Alright? So you have heart failure, but you haven't really had any exacerbations. vaccinations, you're living your life normally, you've had this disease, it doesn't really affect you, you're good. Class 1. Class 2 is mild symptoms. That means that you don't have any symptoms, or XX is kind of how we abbreviate symptoms in the medical field. So mild symptoms are like, you don't have any symptoms until you run a marathon. You know, when you're doing strenuous activity, then you start to feel it. Otherwise, you don't feel it. Class 3 is moderate symptoms. And what that means is if you just do something as simple as walk to your mailbox, you start to feel it. Shortness of breath, you get tired, you get a little weary, you can't take another step, you're done. Class 4 is the worst, that's severe symptoms, and these are patients who are pretty much bedridden. If they even go to their bathroom, it's a task. They can't bring themselves to do it. This is when it's really bad. And in this case, that's usually a medical emergency that have to be admitted to the hospital. Some patients do get to this point before they even seek help or even know that they have heart failure. By that time, it's way too late. Okay? So those are the classes. What's a loop diuretic? Remember seeing that in the paper? Loop diuretic? Okay, where? In the kidney. Anyone else? So it's a drug. It's pretty much the most powerful diuretic. What's a diuretic in general?
That helps you lose water out of your
How?
body.
And do what? And pee. Right. So you have all this fluid in your body. You gain all this weight. You have to get it off some kind of way. The best way is to give you this drug, either IV or PO, which is in your mouth. Take a pill, and you just pee. And these patients, it's not like, regular. They have to pretty much be next to a toilet at all times. These are very, very powerful diuretics, the best we have. Okay? All right. So cognition. What's cognition? What's that mean? Your ability to know, to understand, to learn, just, you hear mentally. Why is that important in heart failure? Why is it important in this case?
Because the entire study / experiment is trying to find the best way to improve self-care for heart failure.
Okay.
So it's extremely important to see which one is the best, and cognition is extremely important when you're taking the condition.
Right. So these patients, and not just in this study, but heart failure patients in general, it's a self-care kind of thing. It's something that you have to be very, very proactive about. You have to be knowledgeable about the disease to know how to care for yourself. So in this study, they kind of excluded anyone with any kind of dementia, any kind of cognition skills, because those people clearly cannot care for themselves. Okay? That's why cognition is very important. Baseline. Talk a lot about baseline scores, baseline results. Yes.
The baseline helps you see like where the person was starting from.
Right. So before anything is done, before they're put into any group, they do all these baseline tests, meaning before they do any intervention, they want to see where you are right now as you are, without any help. Okay? That's what baseline means. Intervention. What's an intervention? You guys know this. Come on, you read it, right? Come on, tell me. Besides Sergio. Okay, Sergio.
Intervention is what they did during the study with the TTI group, where where you intervene with their knowledge. So the control group, they only intervene once with a single session, and the experimental group, they intervene throughout the entire month with several phone calls.
Okay. So intervention is pretty much what the study is going to do to the subjects. So, okay. Ejection fraction. Yes.
It measures how well someone's heart is pumping.
Pumping what?
Blood.
Pumping blood. So, what is a normal ejection fraction?
It's between 55 to 70.
Right. And what's the ejection fraction for heart failure?
Less than 45.
or 45%? Okay, so your heart, a normal human being, you're under 30 years old, you're under 25 years old, don't have any diseases, God forbid, hopefully you don't. Your heart should be beating very strongly, very healthily, and ejecting about 75% or 70% of the blood that's in your heart. So don't think that when your heart pumps that all the blood is coming out. That's not true. Only about 75% goes out at a time, and the rest stays behind. Okay? For these patients, only about 45% or below. I did research with heart failure patients this past year, and some of them had ejection fraction like 14%. It gets pretty bad. And of course, these patients are here. So what does that mean if you're not pumping as much blood as you should? What does that do to the body?
Means you're not getting oxygen and nutrients to the rest of your body moving as fast as you should.
Okay, anyone else? What else are you not getting to the rest of your body? What else does the blood carry besides oxygen?
CO2. Like you're not getting things out of your body either, like carbon dioxide, not getting to your heart and to your lungs and everything as fast as it should.
Okay. What about your drugs that you're taking?
Won't do that either.
So you're not really getting much of anything that you need. Okay? What does that do to your brain if you're not getting as much blood? Oh.
It slows down the function, so you're not as sharp as you would be. You're not thinking as fast as you could.
Right, so decline cognition. Some patients exhibit depression where they just don't feel well about themselves, which is kind of a chemical imbalance, but you need that blood and oxygen to make those chemicals work and to balance. So what about your digestion? What happens there? What, takes a long time, maybe not digesting at all. Some patients get very nauseous where their body just can't digest it, so it just, goes the other way, come back out. Yes?
So what happens if like they get a cut, like a big cut? What would happen to it?
Do you think it would bleed a lot or not?
Because then there's no liquids, so there's no like the liquids don't get to the stomach.
Okay, so, they may have open wounds or not healing as well. So pretty much, your body is not really functioning that well in any aspect. For eyesight, anything you can think of is just not working that well. Okay? So what's an outpatient? We talked about outpatient versus inpatient. Were these patients outpatient or inpatient? So what does that mean? Right. Or in what kind of setting? Not a hospital, but like a doctor's office or a clinic. That's outpatient. Same day. You come in one day, you leave out the same day.
I have a question. Where would hospice fit in between inpatient and outpatient? Would that be
So what's the hospice, you guys? Hospice is kind of like the long-term inpatient until you die. So you don't really leave the hospice. You go to hospice when they know that you have like 3 months to live or a very short amount of time to live, and they keep you comfortable. They don't treat you. They kind of let death take its natural course. They'll pump you with morphine so you feel euphoric and great the whole time, but you're gonna die, and you're not in pain, and you're not suffering. You're just letting death take its course. It's the ultimate inpatient experience.
inpatient?
It's inpatient. Well, you don't really call it inpatient, you just call it hospice. It's its own
Yeah.
separate thing. Okay, what does adherence mean?
Compliance.
Compliance. Simple as that, compliance. Anyone confused about that? About compliance, adherence? Doing what you need to do, doing what you're told to do. And comorbid. Talk about comorbid diseases in this article. Anyone look it up by chance? Wanna guess?
Yes.
Okay.
Is it other diseases that when you put them with heart failure that it could be potentially them?
Right, so it's just other diseases you may have that may contribute to heart failure or may get they can add a complication to heart failure. One of those diseases that you pretty much have for the rest of your life. Can you guys name some comorbid diseases that you would think interferes with heart failure. Yes.
Asthma.
Okay, asthma, because you can't breathe and you have the fluid in your lungs. What else? Diabetes is a big one. One more. There's one more that's really big. Think about the heart. Come on, you guys are future doctors, right? You guys gonna be doctors and in the medical field and that.
Maybe atherosclerosis is
Hmm?
atherosclerosis.
That's a good one. Yes. What's that? Can you explain what that is?
I think atherosclerosis is not like constriction of the blood, of the vessels for the blood to go through.
Not exactly constriction, but there's blockage. You know how they say watch your cholesterol, because cholesterol can build up in your arteries and cause a blockage and take a heart attack or aneurysm or stroke. Another one, there's one more huge one that I'm thinking about. It's a silent killer. Everyone has it. By everyone, I mean everyone, guys, I'm telling you.
Is it cholesterol?
Not cholesterol.
Blood pressure.
Yes, hypertension, high blood pressure. That's a major one. Many people with hypertension that do not control their hypertension end up in heart failure. So that's a major one. Okay, so let's go on and start on each section. So what I did here in this presentation is that I went section by section, starting with the introduction and going to end with discussion. And I pretty much made summary points, and I'm going to cover just the main points. And I want you guys to comment, interact with me, add your own spin on it or your own opinion, ask questions, and we'll move on from there. Okay? Seems fair? Did you guys read this article? I'm getting this really eerie feeling. I don't know what it is. It's like right here. But you guys really didn't read it. Did you read it more than once? Did you take notes? Did you at least take notes if you didn't read it more than once? Okay. From this point on, if your professor gives you, especially a journal article, you have to read it more than once. You at least have to read it slowly. I'm talking about 3 days. Take a section, read it, take notes, put it down. It's very dense material, it's very complex. You guys are not doctors, you're not pharmacists, you're not nurses. You don't know this stuff. Some of the definitions you didn't know. So it's a lot to take in when you don't even understand half the concepts. So take your time with it. Don't wait till last minute. Go back, take some notes, highlight some things, write some questions. I told you guys, I learned like a kindergartner. So I will take my notes on the back. If I have a blank page, I'll go on the back and I'll write a chart. Okay, like I don't understand this, so let me write a chart. Okay, you have heart failure here, do you have shortness of breath here, and then I understand it. Okay, so don't be afraid, you're not stupid, you're not dumb. Einstein was called dumb and retarded and all those terrible things when he was 12 because he took notes. He wrote everything down. He's like the most genius person we know. So don't be ashamed. Okay?
Everybody who reads these are very dense. They're designed to be dense. They're not made for easy, fun reading, on a Saturday afternoon. These are supposed to be thick. You need to take time with them. Everybody has their own system for how to do it. I color code things. Yellow means that I need to go look up the word. Green means that it's a result. There's all different ways to do it. I'm sure Dr. Gordon has her own way to do it too. Everybody develops their own, but chances are if a professor gives you one of these, you're probably going to see at least one test question based on an article that they gave you. So that's really important that you understand what you're reading. And it does take days sometimes to read them.
And most times when you read them, you're going to be expected to comment on them. Most times when you read them, you have this thing called Journal Club where everyone is expected to ask a question, to know about the material, to pretty much dive deep into it and discuss it. You can't just sit idly in the corner. These things are like 3 or 4 people sometimes. The max I've been in is like 10. And you stand out. If you're the one that's quiet, you stand out. So you have to be prepared to discuss. That's why understanding this material is very important. And I would say with that, when you go to study, general chemistry or biology, take that same study skill and apply it to your studies. You would know things that much better if you did that than to just skim over it. So you had a question. introduction, they said that 5.8 million people in the U.S., 283,000 deaths per year, and there's 39.2 billion per year that's spent on this disease. Why is that all important? Why are we seeing this in the introduction? Sergio?
Like they said, most of these patients are elderly and have Medicare, so it affects everybody because they're the ones having to pay that $39.2 billion to pay for them being readmitted into hospitals and for death.
Okay. It's also very important because these patients, it's a lot of them, it's a lot of deaths, it's a lot of money, and they don't get better. So we're pouring all this money and time and effort into all these people who are not going to get better. Once you're diagnosed, you have like 6 to 8 years to live. If you do everything correctly. Like if you follow it by the book, you're doing everything correctly, your diet is changed, exercising, your heart's going to give out in 6 to 8 years. 8 years, 9 years if you're, really diligent about it, but you're going to die. And it's going to be a very painful process the whole time. So, what did I say was the purpose of the introduction? Why do we have the introduction? What are some of the questions the introduction asks and answers?
Cooper, you look like you wanted to answer that. You're going to need to repeat it for him, but he wanted to answer it anyway.
Oh, okay. So remember in the lecture about writing a lab report, and I went through each section and said the introductions for this, the methods for this. What is the introduction for?
Like to give background information on what you're doing.
Okay, that's one. Anyone else? What's that big question you asked about subject? Right, why do we care? Why do we do this experiment? Why do we need to do this? What questions are we going to answer here? So that's pretty much what they do in their introduction. So they also say that self-care includes symptom recognition, weight monitoring, dietary salt restriction, exercise, medication adherence, and the plan for exacerbation. Anyone have any comments or questions? Why is this important for self-care? Why is salt important?
To manage your cholesterol levels.
Repeat it.
So
So salt makes you retain fluid. And why do we hate fluid in heart failure?
It can get into your lungs and make you more susceptible to pneumonia.
Right, you can become short of breath because of the fluid in your lungs, you gain all this weight. It's pretty much a sign, you're pretty much hurrying the process. So with heart failure, you're going to retain fluid anyway. If you're increasing your salt intake, you're just going to shorten that time it takes to gain that fluid. Okay, that's why it's important. What about exercise?
Lower blood pressure, lead stress on the heart if you're doing cardio.
Right, it's the reason that we all exercise, right? To stay healthy, to keep your body in motion. So do you think that these people with heart failure is like on the treadmill running like a 7.0? Anyone? What kind of exercise are we talking about with these patients? Jogging? What do you guys think? Just walking. Just, maybe 10 minutes today. Tomorrow you may do 15 minutes. You may be able to do 20 minutes. It may get better over time. And usually that's what happens with these patients. They'll start off with a 5-minute walk, and they'll walk from maybe like here to the end of that table. They'll be tired by the time they get there. They'll be exhausted. But the goal is to get them into moving and to repeat that every day. Okay, so let's continue. All right, self-care is important because it reduces readmissions. This is important for our Medicare and Medicare requirements. Anyone keep up with this? Any notes about the Medicare requirements of heart failure? No one read that part in the introduction? It's like the first page. I told you guys, I have a feeling right here. I feel it. Yes.
Well, within the third paragraph, Medicare has adopted discharge limitation as a core quality measure that assesses whether patients admitted for heart failure are discharged home. And this, the note I put with it was that business-wise, it would be cheaper than readmission.
Okay. So what's required for Medicare? What does that mean? What do they require the hospital to do for these patients with heart failure? Yes.
Basically, they require the hospital to educate the patients about how to take care of themselves once they're discharged from the hospital.
Right. Medicare already requires them to do some form of education before these patients are sent out. This is a disease that takes every minute of your day. You have to consistently think about your heart failure. When you wake up in the morning, you have to weigh yourself. Make sure you're using the restroom. Make sure you're taking medication. When you eat, make sure you have less than 2 grams of salt. When you drink, that's a day, 2 grams a day. When you're drinking fluid, make sure you limit it to 2 liters a day. This is like something that takes all your time. Okay, so you have to be educated. That's something that you can easily just do tomorrow. So, what's the controversial part about the requirement? It's right there in like big bold, not big bold, but like it's all in caps. It's all in caps. Written. What's the problem with something being written for these patients? I want to hear it. They may not be able to read. Okay, what else?
Since they, the, cognition problem, they won't be able to do that.
Right, what else?
They might just make it up, just to get their Medicare funding. They might write down things that they don't do, like things that, like they might write down that they do 10 minutes of exercise a day, but really they don't.
Okay, this refers to the instructions the hospital has to give to the patient. Yes.
The large problem is health literacy.
Right,
How much of the actual language they understand.
right.
They can read it.
Anyone else?
Even if the patient understands what they need to do, they may not be able to fully comprehend every aspect of it because they're in that state where they're not at their healthiest.
Okay.
Well, personal motivation, whereas if you have someone talking to you, you have more motivation because, they're trying to motivate you to be a better self. Whereas if it's just written down, you're just going to say, it's not really as important.
Right. So the current practice is you go, okay, they take an echo, which is an echocardiogram, which is the tool they use to measure your ejection fraction. You know what that is now. And they say, okay, you have heart failure. Here's a stack of paper about your disease. Here's your medication, and you can go to the pharmacy, pick it up, and you're good, bye. That's what we do now. It's sad, it's funny, but it's so true. Like these patients are well above their 50s. They have heart failure. They give them this package, which is probably a few pages long, and they send them on their way. Also, what about different sites? If I went to Piedmont Hospital here in Atlanta, and they gave me something that's 5 pages. I went to Emory, they gave something that was 15 pages. I went to Grady, they gave something that was 3 pages. What's the issue with that? This is not standardized. Medicare tells the hospitals to do what you want to do. Like, just give them something that tells them about their disease. What's the issue with that? Is that a problem? Is that good? That's fair? Jump out there, guys.
They might not tell you everything you need to know.
Okay.
Not everyone is getting the same information.
Right. Not everyone's getting the same information. So if I'm going to a hospital that, is in a poor neighborhood and they don't have a lot of funding, they don't have a lot of time to see patients, it's like 1,000 patients in the hallway, and you have heart failure, but there's a bullet wound over here, I'm going to give you your page, I'm going to keep it moving. Okay? That happens. That's a sad thing that happens with heart failure. But that's what we actively have right now as our system. Okay? Think about it. So, also Medicare requires that it must be documented while hospitalized, no requirement to report the extent of counseling, no requirement of post-discharge or follow-up counseling. So all they require is that you get this pamphlet about heart failure. Okay? And you're going to have to follow up with these patients. You don't have to document anything that said that you did counseling. You just have to have them sign and they receive your pamphlet. And that's all they require. Okay? Anyone not catch that in the introduction? Anyone not read that? Okay, got this feeling in my stomach. Alright, so I drew a little diagram here, and when I take notes, I usually do these diagrams in my page. page just to kind of understand what's going on, because what it took them 3 pages to explain to me in the actual article, it took me this little chart to understand without having to go back and take all these notes and be confused. So we have this simple chart of inputs and outputs. So inputs is like a reinforcement. We have low health literacy. We have 1 teaching session or a pamphlet, and the outcome is, readmissions, exacerbation of symptoms, increased expenses, avoidable emergencies. Okay? Any questions? It's that simple. It kind of sums up the introduction, right? Everything we know. Okay. So remember I said that the purpose must be in the introduction, and most times they do write the purpose in the introduction. You want to catch the purpose? It's usually like the last sentence. Gave you a clue last time. I said it's usually the last sentence, the last few sentences of the introduction. Yes.
They were examining whether the benefits of interventions differed by literacy level, which previous studies did not.
Okay. Anything else? What's the purpose of the study, guys? To determine, yes.
The different effects of having one-time education, like right before the patient is discharged, versus the one-time education and follow-up phone calls and counseling sessions for another, few weeks or months or so after the discharge.
Okay. Simple. Okay. So we're gonna move on to the methods and the overview. So what I did was, in the methods it had certain subtitles, and I pretty much organized this presentation into those subtitles. So in the overview, they said, what's your name? Structure.
Yeah.
What's your name?
Yeah.
Yen. Well, she pretty much just told us what the methods were. They had 2 groups, a single session teaching group and a single session plus follow-up phone calls teaching group. And the main outcome was they wanted to measure the intervention effect on death and hospitalization in 6 to 12 months. Okay? And I put in future papers. So this paper is a preliminary paper. It's one of those papers they put out like halfway through to kind of update on what they're doing, or to kind of give a preliminary, like a rough draft kind of write-up of their study. But in the future paper, they're going to cover hospitalization and death. And when you guys go into the medical field, you'll learn that's all we care about. I don't care if they get more knowledgeable. I don't care if they learn more. If they're alive longer and not hospitalized, that's what makes a difference in healthcare. I don't care if it's a drug, an intervention, a new adopted strategy to treat people. If they're not prevented from dying and they're not prevented from hospitalization, we don't care. It's null and void. We don't care. We can't adopt it. We don't care about it. Is that understood? Anyone have any controversy about that? No? Okay.
You're a monster. But I like it. It's true.
It's very true.
It's true.
In pharmacy, we have thousands of drugs that come out. Thousands. There are very good drugs. There are very effective drugs. There are, used across in Europe and Asia. But here, if it doesn't prevent you from dying, if it's not better than what we already have, we don't use it. Oh well. Null and void. Okay? You have a comment on that?
No, that's true. It's sad, but it's true.
Yeah.
It's the way it works.
But there are other sciences that will get to those other
Yes.
questions in there.
And that's fine. And you can look at those questions, and now we know. But until we adopt it into practice, it has to be effective in terms of preventing death and hospitalization. There are scientists that answer those questions of how, what, when, where, why, but nothing's going to be adopted until this happens. That's how it goes. All right, so we talked about this. The participants, it was a time frame between 2007 2009. It was in these 5 different areas across the country in the sites. Any questions, any comments about that at all? Okay. All right, participants. They must have a diagnosis of heart failure with ejection fraction less than 45%, class 2 to 4, which is from here to here, mild to severe, form of heart failure, and they must have had symptoms in the last 6 months. They must use a loop diuretic currently only have 3 loop diuretics that we usually use. Speak English or Spanish, and they must have a cognitive function mini-cog test. What is a mini-cog test? Anyone look that up? No? Guys, that feeling in my stomach is overwhelming. Yes.
Isn't a cog test just kind of like testing to see how well you can comprehend and understand like what you're being tested on or what you need to know?
Did anyone look up the questions for this test? You can easily look it up. You can type it in and it'll give you the whole test. Yes.
I found that it should only take about 7 minutes to complete the mini-cog test.
Right. It's a really short test. The regular cognition test takes forever. It's about an hour long. The mini-cog test was kind of developed to prevent exhaustion from the patient and the physician standpoint. So it's 7 minutes. And the kind of questions they ask are very simple, like what is your name? What year is it? How many children do you have? It's things that you would know. You don't have to do anything like, define the law of relativity or anything like that. It's very, very simple things that you should know just to function on a daily basis. What about this part that says symptoms in the last 6 months? Anyone have issues with that? Any comments about that? Does that stir any controversy with any of you guys? Should it? I mean, there's no right or wrong answer. You guys don't know. You got in that school, I understand. But what do you think about that? Symptoms within the last 6 months. Yes.
I'm gonna explain based off of what you said before, like with the class 2, like how they run a marathon. Like normally people, I guess, kind of train for a marathon, so maybe it wouldn't be as, like you wouldn't notice it within 6 months or something.
Okay.
Like maybe more spaced out between marathons than 6 months.
Okay.
So it'll take longer to notice.
So with these patients, if they don't have a symptom in 6 months, they probably are in class 1. They probably don't even have any symptoms. The symptoms in this disease and exacerbations happen so often that they will have, in 6 months, they probably have 6 different things that happen to them to show their symptoms of heart failure. So 6 months is a pretty good time. Okay? So for recruitment, they approach the patients in an outpatient appointment. They had informed consent. The research assistant gave them a baseline questionnaire. They all had an initial education session at the site performed by a master level health educator. It was 40 minutes long. They had a review of self-assessment, exacerbation plans, salt avoidance, exercise, medication adherence. They all received an educational manual and a digital scale, and they were randomized to 2 groups. So this is what happened with all the patients. Anyone have any questions about this or any comments about this? Did you guys see this in the paper? You guys remember this from the paper? That's good, yes.
One of the things I thought was great about the study regarding the randomized groups was that those groups included people with high health literacy and low health literacy.
Right. That's very true. Both groups had a good selection of people who had really good health literacy and very bad or poor health literacy. So it wasn't, they weren't separated in that sense. What about this part that says it was 40 minutes long? Anyone have issues with that? Yes.
I feel like by the end they were probably coming out. Because if you're a patient and you're in there and especially if you have low health literacy and someone is telling you all these things, if it takes 40 minutes, you're not getting just accurate instructions, you're getting an entire overview. And for a patient, you don't want that usually. If you go to the doctor, you want to know what can you do to fix this, not, exactly everything.
Right. So this can lead to patient exhaustion. So by the time they hit 20 minutes, they're already out. And they did this at the time of discharge. So they've probably been sitting in his office waiting. They got an exam. Now it's time to go, and they had to sit here for 40 minutes about heart failure. Okay? What about the digital scale? Why is that important?
Just how much you maintain as a result of the water retention.
Right. So these patients have to weigh themselves daily. So they gave it one scale. Okay. All right. So the BEI group was the control group that had one session of recruitment and were sent home. Then the TTG group got self-care training, more information about daily weight and self-adjustments. Okay, so for the TTG regimen, it was 4 weeks long that had 5 to 8 follow-up phone calls from an educator to reinforce education, about 10 minutes long each. We try not to overwhelm the patients with too many calls, and the goal was to access the patient's knowledge and give more info and encourage patients. So call 1 and 2 are just a review about what they were taught the first time, and then call 3 through 8 were more of a reinforcement thing, and to kind of see how the patients were coming along. So this means that the patient had to do self-reporting on how well they were doing. So what's the issue with self-reporting in studies? What does self-reporting mean? Shout it out.
Reporting yourself.
Right, reporting yourself. So what's the issue with that? Like, how can that kind of skew things?
Honesty.
Honesty. Right. And what's the issue with that? Like, why do we care?
It's not the truth.
Not in chorus form. Someone like sing out loud.
It's not always accurate.
It's not always accurate. Like, yeah, I'm not eating any salt. I don't drink that much. I weigh myself every day. Who knows? It's not perfect, but for a study like this, you will see this often. They do depend a lot on self-reporting from subjects. So it's not the best thing that we have, but, well, it's not the best thing, but it's the best that we have when it comes to studies like this. Any questions about that? All right. At baseline, they took race and ethnicity, insurance information, income, subjective, socioeconomic status, education, medication use, and all this came from the patient. So they interviewed the patient and they asked them about, how's their income, their education. Once again, same issues with self-reporting. All right, the age, gender, comorbid conditions, prescribed medication, lab tests, and the echocardiogram came from their medical charts, so it's more subjective, it's more accurate in a sense. And the NYHA class, which is this here that we use to classify the patients, was pretty much assessed by an interview. And that's typically how it's done. They have to ask the patients, how often do you feel this symptom, how do you feel, when did you feel this? How often do you feel that? How are these symptoms? How does it feel when you do that? And that's pretty much how we put them into a category. Okay, so the baseline interview, they also had like a quality of life, or this is the health literacy test, and this is just to show how the test is performed. So at baseline, they had to do all these things. Outside of the 40-minute long session to teach them, they also had to do all these tests to get a baseline knowledge of the quality of life, the literacy, and their basic knowledge about heart failure. Okay? This is also the heart failure symptom scale, another test they had to do an interview. This is the knowledge and self-care assessment. And all these bullets here are questions. So 8 questions about that, 10 questions about this. Basically, all these tests that have to do at baseline. Okay, so the results. So from all these studies, from all these centers, they had 2,848 patients eligible for the study. 1,006 in that approach, 55 were refused, and 682 were ineligible. That left us with 605 patients who agreed. Okay, and then you can refer to page 11 to see the breakdown of those patients in this article. The age pretty much was like 60 years old, give or take. About half and half female, 50% or more were minorities, and 37% had low health literacy. So in general, the TTG group had a greater increase in general knowledge. They knew more about weight gain as to sign of risk heart failure. They knew more about weighing themselves in the BEI group. And 80% of all the patients in both groups knew that shortness of breath, which is SOB, swelling of legs, and waking with shortness of breath was signs of heart failure. Okay, so The TTG group also had greater knowledge about appropriate salt practices. 90% of them knew more about how much salt to intake versus the BI group only had 37% of people who knew about that. And they had a greater knowledge about what was considered a safe amount of salt. So changes in self-efficacy, the TTG group had a greater change in the BI group, and changes in self-care behaviors were the same. So what's the difference between self-efficacy and self-care behaviors? Is it the same thing or something different? It's obviously something different, right? So what's the difference in it? What's self-care behaviors? What they actually did, right? And what is self-efficacy?
It's the ability to actually manage your heart rate.
Right. So we're talking about ability versus what you actually do. So the people who got those phone calls in the TTG group had a better ability and they were more prepared to take care of themselves. But when it came down to what they actually did in self-care behaviors, they're about the same. What does that tell you? How you guys feel about that? Anyone catch that in the paper and have like a big exclamation mark about that? Anyone? No? Any thoughts about it now? Yes.
I mean, sometimes all that kind of thing because people are taught the right thing, but they don't choose to learn the right thing. They choose not to.
Okay. Yes.
I guess your feeling that everyone is capable of controlling their symptoms. It's just a matter of how much education they have.
Okay. Any other comments? Sergio?
The self-care behaviors, the TTG group, although it wasn't a great change, it was double the amount of change in the BBI group, around 1.8 and 3.2.
Right. And this is where I told you guys that statistics is very important. I didn't really want to do it here because you guys don't know enough about statistics yet, especially research statistics. But even though the raw scores say, oh, it was 1.2 versus 4.5, statistically and clinically, that's not that much of a difference. And if you could interpret the statistics, you could read that and you could be able to understand that. I'm not going to hold it against you now because you guys don't have that much knowledge. I'm still really learning about it, and it's something that you have to learn over years. But yeah, the raw score may say it's more or it's greater, but statistically, it's not that great. Okay. In quality of life, they said that the TTG group had an increase of quality of life versus the DEI group. So, discussion. So remember I told you, I gave you that big clue that the discussion portion of the paper is the most important. You guys remember that at all?
Yes.
So did you guys read the discussion? So this is where I let you guys take over the discussion. I'm going to kind of sit back and just be a moderator. But you guys need like a minute to read it, or you guys going to start now? Thoughts and report. Offering a buy. Okay, you guys need a minute to read it? Question like that?
Oh, I was just gonna I was just gonna ask you something.
Oh, okay. All right, I give you a minute to read the discussion. Take notes, write your comments, your questions, and then we'll reconvene in like 5 minutes and then discuss some of the topics I brought up here. Okay? is your floor. I'm just here to moderate. Yes. Well, let's just start with the purpose of the discussion. We went over the part of the lab report. Why do we need a discussion session or section? What do we do? What do we write about in this section?
Discuss the results and why that happened and why it didn't happen.
Okay. Anything else?
Actually,
Right about future improvements.
Okay. Anything else?
It's like a different way in this study.
Okay, things should have done differently. Okay, so with all that in mind, did you guys see that in this section here?
Yes.
Okay. So what were some of the points they brought up that you found interesting? Let's go with you here.
They said that their data could have been a little bit skewed because people who were a little more educated, who was affected by heart failure and undergoing these trials, they could have had a different result because they had a higher education starting off than the people who didn't have as much education.
Okay. Anyone else found that point to be interesting? Want to comment on that point?
It's kind of like a couple paragraphs now they were talking about something about high salt foods. Like people who already had kind of an idea about it, so they didn't see an improvement in the number of people who learned about which foods to avoid for high sodium. Which it doesn't mean that they weren't helpful. It's something they already knew.
Okay, so that's two different points. I'm going to write them on the board, and then we're going to address those. So we talked about low lit versus high lit. Talked about previous knowledge. I don't want to like run over someone else's literature. Any more comments about the low literacy versus high literacy? Yes.
I found it interesting because they compared results to previous studies that tried to achieve it, but they didn't achieve it. And they even said in that paragraph that they thought it can be overcome, but it was like giving advice to other future studies.
Okay.
Regardless of the differences in baseline, one of the paragraphs talked about how self-care behaviors improved much more than knowledge. So it discussed the fact that maybe a program that had less educational content and greater emphasis on what you're actually supposed to do would be better, which would kind of cut out the differences between low health literacy and high health literacy, because if you just know what you're supposed to do, and that will help you, take care of yourself better regardless of what's actually causing your symptoms.
Right. So they said that maybe they taught a little bit too much information. They said that, well, the TTG group had all this knowledge, but when it came down to it, maybe that 40-minute session was enough, or maybe the amount of knowledge you know doesn't really correspond with what you actually do. They also said about this low literacy versus high literacy is that, I don't know if you guys caught it, but you want to comment on it before I say something?
The
What did
low
you say? Huh?
and high health literacy.
Yeah.
Even in their studies, they weren't able to significantly reduce the difference between the two of them.
Exactly. That's what I was going to comment on. So they said that between the two, they both improved, but no matter what they did, they couldn't get the people with low literacy to meet the same level as the people with high literacy. They're pretty much both increasing, but they never kind of meet in the middle. So the people with high literacy always will do better than people with low literacy, even if they're given the same information. Anyone catch that? Any questions about that? Any controversy? Anyone mad when kick that book bag about it? Anyone? I kind of want to kick my book bag about it. Go ahead.
But they did say that it might be best for those with low literacy, instead of just giving them straight out information, to have videos instead of just static, just to show exactly what to do.
Right. And this is something that I think that medicine is kind of moving towards, is learning or coming up with different ways to teach patients. I know in pharmacy, one of our biggest jobs is counseling. We have to actually counsel how to take it, how to recognize when you're in trouble with the side effects, when to call a doctor. You have to know these things and teach it to the patients. And sometimes if our pharmacy is on Buford Highway, where there's 20 different ethnicities and everyone speaks a different language and I only speak English, how can I teach my Vietnamese patients and my Hispanic patients and my Indian patients, how can I teach them all the same and have them all on the same level? I can't. So they're trying to think of ways to kind of implement maybe pictures, maybe videos to kind of help these patients get to health literacy enough to take care of themselves. And you guys are the next generation, and you guys have all these resources here in Atlanta. If you want to go to the medical field, I highly suggest you guys do something with that, because that's like on the rise right now. Any other comments about the literacy that they covered? Okay, let's move on to the previous knowledge point. Yes.
One fact I found interesting was that 24% of the people that were in the study did not know that shortness of breath was a symptom of heart failure, and even through both of the teaching programs, there was hardly any improvement on the 24%.
And shortness of breath is a big one. It's something that even if you're not weighing yourself and you don't know how much, I don't know how many pounds I'm weighing. I don't know how to weigh myself. Okay, fine. But shortness of breath is something that is very apparent and very catastrophic if it's not treated. And the fact that these patients still didn't really know that shortness of breath was an issue is an issue. Okay? Anything else about the previous knowledge? Something big that I saw, I'm like, oh my God, yes. Go ahead.
I thought it was interesting how they said that it would be easier to teach patients that weren't already stable outpatient.
Okay.
Like, to teach people that were in the midst of a observation. So it was like for the stable people, it probably didn't reach them as much because they were still doing it.
Okay.
So the better to teach people that were in the midst of observation.
Right. Anyone else catch that one? So it means more inpatient, right? Like they're laying in the hospital bed, they're all panicked and scared from this exacerbation they just had. This is the time to intervene. Not when they're walking fine to their doctor and coming out of the hospital and they're like, oh, I know what to do, I got this. Maybe we should change it to an inpatient site where people are actually, in the bed, concerned, want to do well, just had this crazy episode of shortness of breath, couldn't sleep at night, couldn't lay down flat. This is the time to intervene. Any other comments about previous knowledge or that point that she just brought up? Yes.
There was one point where it said that most of the patients that had baseline knowledge were because they had heart failure and immune, so they're already accustomed to it versus someone that just got
Excellent. Anyone else catch that? Anyone hear what she said?
No.
Repeat it.
The people that had the high baseline knowledge were people that already had heart failure for many years versus someone who just
So remember when we looked at the patients and the criteria, they didn't judge how long you had heart failure. So if I'm a person that I'm like 70 years old and I've had heart failure for 10 years, I kind of know this stuff. I've lived it for 10 years. Versus someone who's newly diagnosed where the disease is very new and they don't know much about it. They may benefit more from this study than someone who's been walking this walk for a long time. So that's something they can probably address next time in their future studies. Any other comments about that point? Yes.
Well, I saw something on here that said that even though that's majority of them were enrolled in previous heart failure, or seminars or information studies, that they didn't know, 24% of them didn't know that shortness of breath is a sign of increasing heart failure.
So you're saying that even though they've had it for a while, it still may not mean they know how to
It's not
care.
sinking in.
Right. Okay. Sorry, Jill?
Also with the leg and ankle swelling, which is one of the symptoms, 16% did not know that it was a symptom, and then only 8% of the 60% actually learned this over the 1 month follow-ups.
Okay.
That was in that one group. So it shows that it requires continuous repetition for somebody to learn what the symptoms are and exactly how to go about it.
Okay, good. Any other points from the discussion before we move on? Okay. Yes.
It said after that it would be easier to teach it to the patients that are actually having an exasperation rather than the stable ones,
Okay.
so that they could better understand it. But I kind of feel like that would maybe, I guess, skew that the voice skew like the results in a way, because if they're if they're living the symptoms and if they're at that like high risk point, they might not be able to, understand. And I don't think that would necessarily help.
Okay. What about the part where they talked about, so they talked about their control group, about the BEI group in this 40-minute long session they had versus what's currently enforced. What did they say about that? Yes.
They said that in the control group, even though they got only the 40-minute session without the extra phone calls afterwards, they're still getting a better, they're still getting a better education than any normal heart failure person out there today, just getting the packet and being expected to read it, because they're getting like that one-on-one time with someone. And I think it's better at least to do something like that, where they have that chance to talk to someone. So even if they have a low health literacy rate, then like if you're reading a packet and you don't understand something, who are you gonna ask? Versus if you're sitting there in front of someone and they're already there and they know what they're talking about, then they can better understand what the conditions are like and what they have to do if they have symptoms.
Exactly. So I'm going to ask you guys, if they address it in the article, I'm going to ask you, if they use a control group where it was the thing that we use now, it's just giving them a pamphlet and let them go home, and then you have the TTG group, how would that make their results different than the results they have now? They addressed it here, but I'm going to ask you guys in case you missed it. Yes.
If you have the control group, then you'd be able to have something to compare your experimental groups with.
They already do. They already have the BEI group. But let's say that instead of the BEI group, they just had whatever we do now. They go to Grady or Emory and they do the same thing that Medicare requires, give them a written pamphlet, move on. How would that affect their results? Will it look better? Will it look worse? Look at it. It make a huge difference. Why?
Your BEI group is being informed in a 40-minute session versus a group of people that just get a book that they never probably won't open.
Right.
So the difference between the two.
Will it be better results or?
There's
Right. It'll be better results. Any other?
Yeah, I was just gonna say the results might not be the results won't be as high for that control group as it would for the BEI. But if you're looking for something to compare to the TTG and maybe TTG groups, they have a lot more improvement, and that would be the way to go.
Right. If they did that, it would seem as if the TTG group is way better than what it may actually be. Okay? Any other comments before we move on? No? So the big, oh, go ahead.
Sorry. Kind of the last paragraph on the first page is talking about how knowledge and behaviors aren't really tightly linked.
Right. So how do you interpret that?
Because from what I could tell is that the self-care behaviors and the self-efficacy both improved for both groups, but that knowledge didn't really jump up that much, which made me kind of wonder if if they should be worrying more about the self-care behaviors and the efficacy instead of the actual education, because you might not be able to understand why it is that you have to do these things, but you just have to understand that you have to do these things.
Right. Okay. So the big question that we all ask at the end of going through a journal article is, do you buy it? So as students, as science students, remember I told you guys last week, just because it's in black and white and it's published, don't make it true. Don't make it, I shouldn't say true, doesn't make it law, okay? So it's up to healthcare professionals and people in the field to determine, are we going to adopt this as something that we follow? So I'm going to ask you guys, do you buy it? Do you think that we should treat heart failure patients in this way, giving them counseling and giving them more than a pamphlet. Do you buy this article? Do you like it? Do you buy it? Who says yes? This is the way to go. I'm all for more teaching. Who says no? So someone from the yes group, tell me why you buy it.
I don't see how you can go wrong with educating more people about what they need to do to treat this health issue.
Okay, so if we took this article and we implemented this into our daily practice, what would it take? What kind of resources would we need? Shout it out. People, money, what else? Time. Who would do this? The nurses, the doctors? Do they have time to do this? All these patients? Do you remember how they said it's like millions of patients with heart failure? Do you think these nurses have time to call all of these patients?
You probably have to educate people to do these things.
Okay, you have to educate more people
And make the calls.
to make the calls. What else are you gonna need?
I was going to say that for the people who would be educating the patients, you want to make sure that you had some, like the Vietnamese people and Spanish people, like people who spoke different languages.
Right, you're gonna need someone from every walk of life that can kind of speak that language or relate to that patient, the patient can trust. What else do we need? So we have money, people, education, resources. Probably gonna have to outsource this information to someone else or this work to someone else. So it probably won't be your hospital doctor or your nurse. It may be some company that does this independently. You know, you have to pay them to do it. What else do we need?
I mean, patients would also need to be like willing to participate as well, because some patients at that point, they might just not give in because they're too tired and worn out,
Right.
and they're just ready to give up.
We're gonna need some consumers. We're gonna need people to actually follow this and go through with it. Yes, to the back.
If we do implement this, then we would have to come up with some sort of consistent information to give all the patients. They can't just be like a pamphlet where it varies depending on which hospital. But we have to come up with one collective, like set of rules or information to give all the patients like across the entire country.
Okay. How many of you guys think that this, if sources were unlimited and we can actually do this, who thinks that it will work? Why? Tell me something like that we have currently in healthcare that we've done this with and it kind of worked. Yes.
We do this with people who've had strokes.
Okay.
Who've had strokes, we go back and we tell them what to look for, and if you encounter these problems, what to do in order. Also, you also tell them like physical rehabilitation, also their diet, kind of exercises they need to do. So if it works, if we're taking that as an example, if we can see proven results from that, why can't we see it in this?
Okay.
With maternal and neonatal tetanus
Okay.
in third world countries and countries that are just starting to develop, we can see that just by mere education, proper ways to deliver babies and sanitizing medical equipment, that the reduction of MNT is far greater.
So I'm going to tell you my opinion for sake of some time. I don't buy it. I don't buy it. The reason I don't buy it is because, yes, all these things would work with unlimited resources, but we don't have unlimited resources. This is a lot of people. This is not just people, you know, a subpopulation that we have to help. This is a lot of people, and it's going to be many more people in the future because of the increase of obesity in this country, because of our fast food culture, because of our hypertension. This number and this money is going to grow exponentially. I don't think we have what it takes at this point to address this problem. I also don't buy it because this paper does not address death and hospitalization. They don't have any data on how this is going to help people live longer. So before we use all this money, all these people, educate all these people, get all these college students to volunteer, which is probably going to be what it's going to be at first, volunteer spots, the patients to commit to it, we're gonna have to see some numbers, and that's how research works. Before you implement anything and spend money, because there's not a lot of money in research, just gonna put that out there. I want you guys to go into research, but just know it's a field of passion that you really have to be passionate about, because it's not unlimited resources. Okay, so I don't buy it. I think it's a good track for heart failure, but I don't think it's the end all be all. Yes.
On page 7, the top paragraph, it says that specific hospitalizations were reduced by 34%.
Okay. Any other?
I think that was the only statistic regarding hospitalization.
Right.
We did have 2 people in the BEI group die.
Right. So you have to be careful with these papers. They will stick little bits of information into the text and say, oh yeah, we decreased hospitalization, but there's no charts about it. They don't go into depth about it. And that's a big thing, decreased hospitalization. If they don't talk about that in depth, it's probably not that significant. Okay? So that's all I have for you guys. It's been a great journey with you.